I'd like to introduce the next speaker, who you've heard a little bit about when we talked about our ENT colleagues. And the surgery, as you've heard, really has become a marriage between neurosurgery and ear, nose, and throat because of just the benefits we've had in terms of healing, of access. It's made, the teamwork approach has made this a much better procedure for patients and all. So what I'd like to do is introduce to you someone who many of you may know already, Dr. Peter Hwang, who is the ENT surgeon at Stanford, who's been instrumental in the development of our program for the surgical approach to pituitary disease. Peter.
Thank you, Larry. Thank you, everybody, for the opportunity to speak to you. Just want to echo the sentiments regarding the team approach. And when I was a resident in training, our involvement as residents in ENT regarding the pituitary program where I trained was to manage complications of patients who had bad nasal outcomes after pituitary surgery, because at our program, the neurosurgeons did the surgery by themselves. And it was kind of frustrating to see that, because we saw a lot of things that were potentially avoidable complications. So to be part of this team and to really be embraced by our neurosurgery colleagues is really wonderful, and I think it's a really rewarding part of my practice and also with my other rhinology colleagues in our department. So we really appreciate the fact that we can contribute to the pituitary program here at Stanford. So I'm going to talk about things that happen before the tumor is removed, and then what we do afterwards to make sure that our pituitary patients do well. So you are all becoming very familiar with this type of a diagram showing the pituitary gland here. And it's really essentially in the middle of your head. And so, what are the sinuses there for? Well, one of the reasons that we have sinuses is to give us a nice corridor to approach the pituitary gland. So maybe that's not the primary reason that we have sinuses, but in this practice, it's a very important component. So we can perform this delicate surgery through the nasal cavity and avoid a lot of the potential complications that might occur if we chose a different route. And that's why the sinus surgeons are involved. So there are 4 sinuses on each side. They're air-filled cavities that are located between the eyes and below the brain. They are functional, so if you look at the lining of the sinus, there are cilia there, which are the hair cells that sweep mucus out. And it's very important that we as sinus surgeons try to retain as much of that function of your sinuses and your nasal cavity as possible. There are small drainage openings of the sinuses, so when we approach the sphenoid sinus, which is the gateway to the pituitary, we start with a small opening, and I'll show that to you. And then our job is to widen that to create as much exposure as possible in a safe way to allow our neurosurgery colleagues to remove the tumor. And as far as the function of the sinuses, this is still an open question. We don't really know the answer to that. We talked about one is just having the corridor for pituitary tumor removal. But also the sinuses are there to provide resonance to the voice. So if you think about if you have a guitar and you have a solid block of wood, there's no resonance to that. And the same thing in your head, if you just had solid bone, you would have much less resonance to your voice. So that's one thought. And the second is we think that the sinuses lighten the head. So if you think about a bird skull, it's mostly air. So there may be an aerodynamic component to that. And then lastly, we think that the sinuses serve as crumple zones for protecting the critical structures. So if you were to take a blow to your eye, for example, what would happen is the thin bones around the eye socket would fracture into the sinus, and you get this protective effect rather than having the eye rupture. So the sinuses are there not just accidentally, they're there for a reason, and I think that's part of our approach to this kind of surgery is that we want to preserve and restore function whenever possible. If you were to put a little dot of dye where those arrows are, you would actually watch the mucus be pushed out in a very directional pattern, like currents in a stream. And on this front view, we can see the maxillary sinus, which is the cheek sinus, the ethmoid sinus, which is between the eyes, and the frontal sinus up in the forehead. The one that becomes most critical in pituitary surgery is the sphenoid sinus. You can see that in the back there from the side view. And the pituitary sits just above the sphenoid. So right here is where the pituitary sits. So we want to have a nice open view of the sphenoid sinus to then access the sella, which is the bony shelf where the pituitary sits. And all of those red and blue arrows represent the directional flow of mucus through the sinuses. If you biopsy a little part of that, you'll see these little hair cells, those cilia there, and we can actually show you how they function. And you see that rapid movement like that. So that means that the hair cells are working, the cilia are working, and that's our goal at the end of a procedure, to maintain as much of the ciliary function as possible. Now, there are some important nerves also in the nasal cavity, and this is an important part of our planning for the procedure. So there are nerves that regulate pain, and that might be why you might have facial pain and pressure after our surgery, but there's also very important functional nerves that regulate the sense of smell. So the olfactory nerves, which is that brush-like area of nerves that you see at the roof of the nasal passage, those are not at this time replaceable. So we don't know how to recover olfactory nerves even though they have stem cells in them. And so when we're doing our approach to the pituitary gland and opening the sphenoid, we have to be very cognizant of where those nerves are, because we know that one of the potential outcomes of this surgery is a diminished sense of smell, and I'll show you some of the data on that. But there are things that you can do during the surgical approach to preserve as much of those areas where the olfactory nerves sit in order to make sure that you really minimize the chance that a patient's going to have a permanent loss of sense of smell. So what do we do in the office? I do try to meet with patients before the surgery, and I think that while it's not always possible, I think we get a lot of good information from that session. So we want to find out if our patients have any history of nasal or sinus problems that may affect the recovery. We'll perform a nasal endoscopy, which is a way of using the very same scopes that we use at the time of surgery to evaluate the nasal cavity for any abnormalities before the surgery. And that's also our chance to discuss with you any questions that you have about the upcoming surgery. We have this set up in our clinic where our patients can wear video goggles. So if there's something that's notable, we can actually show that to you when you put these little goggles on, and you can watch along as we examine your nasal passage. And this is a little video that just talks about what we look for when we do nasal endoscopy. So this is done awake with just a topical anesthetic. And you can see some of these various structures in the nose. Now, the sphenoid sinus is in the very back of the nasal cavity, but we have to go through all of these structures or around these structures to get to the sphenoid. So these are all relevant structures. This is the back of the nose called the nasopharynx. And you'll see where it says orifice of eustachian tube at 3 o'clock. That's the connection to the middle ear. So sometimes patients after this kind of surgery have some ear fullness. It's probably because of swelling around the eustachian tube. Now when you come up to the top there at 12 o'clock is going to be the opening to the sphenoid sinus, and so you can see how far back in the nasal cavity we are. So all these other structures we want to respect. We usually try to push them to the side rather than cutting them out in order to preserve as much of the nasal function as possible. So these are all checklists of things that we look for when we do a nasal endoscopy of our patients in the clinic before surgery. Some of the abnormalities that we might find here is a situation where a patient's nasal septum, which is the wall that runs down the middle of the nose, is deviated, and it's pushed, in this case, to the right side. You can see how the wall here bows over this way, and so it narrows access to the side relative to the opposite side, which is more open. Now, we can often work around a deviated septum, but sometimes the deviation is so severe that we actually have to correct that on the way in. So that would be something that we would counsel you about if you were our patient having the surgery and we found that you had a very obstructive nasal septum. Here's a case of nasal polyps, which is a benign growth in the nose representing abnormal inflammation, and these are things that we could also remove on our way to the sphenoid sinus. So how do we create this window for our neurosurgery partners to work? First of all, as I mentioned, we push the structures to the side as much as possible rather than cutting them out. And then you'll see these small openings. So this is looking down the right nasal passage and the left nasal passage. And you see this small opening right here, and you see right here. those are the natural openings to the sphenoid sinuses. So when we talk about that 2 to 4 millimeter opening, that's what we're starting with to create this window. Now you can actually remove quite a bit of that tissue around there and not actually affect the sinus function. And in fact, when we see patients who have chronic sinus problems, and the problem is actually a chronic infection of the sphenoid sinus, this is the very type of surgery that we would do for the patient. So it fits in very much with the kind of surgery that we're doing all the time for other reasons besides pituitary tumors. So then, if you're looking on that right and left side, we're then expanding those natural openings, and you're actually seeing a little bit of the sella on the left side where that light reflection is through the hole. That's actually the sella that will eventually be open to reveal the pituitary tumor. And when we can connect both sides, then we have this much bigger opening. So this is the patient who started with those two small 2 millimeter openings, and we removed all of this tissue that is not going to be missed by the patient to create this bigger window. And this is the preparation. So in the first part of the procedure, it's just the sinus surgeons working to create this opening so that we can start to remove the bone of the cell to expose the tumor. So that is about the first 45 minutes of the surgery is the approach to the tumor. Now you've heard some discussions about brain fluid leaks, and that's certainly something that we try to avoid, but in some cases, when there's a bigger tumor, there's a much higher chance of having a brain fluid leak. And sometimes we need to use additional methods to make sure that if there is a leak during the surgery, which may be unavoidable, that we can get a watertight seal at the end of the procedure. So this is another area where the sinus surgeons can contribute by, instead of using free grafts, which are would be skin grafts, where we would rely on the body to replenish the blood supply by growing into the tissue, we can actually use what's called a vascularized flap, which means we're going to harvest the tissue with the blood supply intact. So that tissue is living, and the arterial supply is maintained the entire time. So what we can do is borrow tissue from that septum, from that midline wall, lift it up, and move it with the attachment of the arterial supply intact, and then just rotate that upwards and to reline the sphenoid sinus to completely seal off anywhere that might be leaking. And that has dramatically reduced the incidence of postoperative CSF leak. And as Dr. Fernandez-Miranda mentioned, I can't remember the last time we had a postoperative CSF leak from pituitary surgery, and a large part it's because of the additional techniques that we can apply, such as the use of the septal flap. So the septal flap is living tissue that we move from one part of the nose to another. It has a very large surface area, so it can cover an extensive part of the sphenoid sinus. The disadvantage of the septal flap is that you're borrowing tissue from one part of the nose to cover another, so that area that you've harvested from needs time to heal, and that is a longer healing time than if you just did the approach without the septal flap. So it takes up to 90 days for that to completely recover with a new layer of mucous membrane. So what do we do after surgery? Well, we want to make sure that our patient's comfort is optimized, and it is unavoidable to have some discomfort after this procedure, but there are things that we can do to help our patients feel more comfortable. We want to also monitor for appropriate healing, so we do that with endoscopy, and we want to prevent scar tissue formation. So we don't want our patients to develop new problems as a result of this surgery. We want to bring them back to where they were before the procedure. So a lot of patients really have never had any issues with their nose or sinuses, and that's where we'd like to deliver them back to. Now that may take months, but that's our ultimate goal. We want to restore that functional nasal cavity, including the ability to breathe well through the nose and to smell. And in fact, in that first couple months after surgery, you'll probably see, if you're the patient, you'll probably see the sinus surgeon more often than the neurosurgeon, because a lot of that critical healing is monitored in those first few weeks after surgery. So unfortunately, patients in the past might have looked like this coming out of surgery. That just looks uncomfortable just looking at the picture. And fortunately for us, this is no longer what we do. We don't use any nasal packing that would have to be removed. after routine pituitary cases. We have lots of other options, and as Dr. Fernandez-Miranda mentioned, some dissolvable packing that really never has to be removed but can be washed out. We do expect you to have significant congestion if you're going to have this type of surgery, and you'll have some bloody discharge that's really unavoidable, but you should not have significant bruising or swelling. So you will feel like you had brain surgery, but you won't look like you had brain surgery. And so there's a little bit of a disconnect there, and sometimes I warn my patients, you might not get as much sympathy as you think because you're not going to look like you had brain surgery. We recommend moisturizing the nose aggressively because the lining of the nose will be very irritated. Remember, we're working through that front part of the nasal cavity the entire time that we're working in the sella to remove the pituitary, so that passing instruments through that area can irritate the lining quite a bit. And then we are also monitoring for brain fluid leak during the time after your surgery while you're in the hospital. Lots of questions about, are you having any discharge? We might evaluate the discharge that's on the tissue to see if it looks more like water or if it looks more like blood. And that's part of our evaluation. We can even do bedside endoscopy sometimes if it's not clear, just to make sure that everything looks okay. So after you go home, then we continue our efforts to have you moisturize your nose, because moisture is your friend. Moisture allows very good healing of the nasal cavity. This is also what you would do if you were a patient having sinus surgery with us. It's the very similar principles. And if you're a patient that doesn't require a septal flap reconstruction, you can start irrigations right away. If you're a patient who's had a septal flap, then we recommend waiting 1 week, so that after the first visit with us, which is about 1 to 2 weeks after discharge, then we would start a larger volume irrigation like this one here that we use. We recommend no nose blowing for the first week. And then beyond the first week, still continuing to rinse your nose. After that first visit, you can start to blow your nose. Then we would tend to see our patients about 1 month later, because that's when we would expect patients who do not have a septal flap to be pretty much done with the nasal healing process, except for the recovery of sense of smell, which can take longer. Patients who've had a septal flap usually require at least 1 extra visit, because remember, we borrowed that tissue from one part of the nose, from the septum, to cover the area of the surgery, and depending on how big the flap is that's harvested, that's exposed cartilage that needs to recover with a new lining. We've done some research at Stanford with new biomaterials that we can use to graft over that cartilage to accelerate the process of healing. But we still recommend a 3rd visit at least, and sometimes a 4th visit at the ENT clinic to make sure that the nasal cavity is completely healed. So I mentioned about sense of smell, and this is something that I think is really important to talk about with our patients, because I certainly treasure my sense of smell, my ability to taste food. And if you lose your sense of smell, your taste will definitely be affected as well, at least your ability to detect flavor. So you may be able to still taste salty, sour, and bitter, but you may not be able to distinguish a lemon candy from a watermelon candy. So we do expect recovery of the sense of smell. That may take several months. Some patients are already noticing an improvement in the first few weeks after surgery. And if you have a septal flap, that is going to take longer for you to recover your sense of smell, but we do expect a good amount of recovery. And as I mentioned earlier, even though you can't see those olfactory nerves in the nasal cavity, they're microscopic, we know the general areas where there are higher concentrations of these olfactory nerves. And so we can plan our approaches to save as much of that tissue that's more likely to have a higher concentration of olfactory nerve. I want to share a little bit of research with from our center, from my partner, Dr. Zara Patel. There are 3 sinus surgeons that are involved in the pituitary program. And Dr. Patel is not only a sinus surgeon, but also a researcher, and her research area of interest is in olfaction. So she has looked into omega-3 supplementation as something that might be used when patients are having skull base surgery. And omega-3 looks like it may have benefits for wound healing and nerve regeneration. So she did a multi-center randomized study. This was looking at 108 pituitary patients, and they were randomized to the saline irrigations that everybody takes versus saline plus omega-3, 2,000 milligrams daily. And we have ways of measuring your sense of smell with objective testing, which are like scratch and sniff tests, and all of these patients underwent that before surgery, and then at 6 weeks, 3 months, and 6 months post-op. And it was a very interesting study because you really saw a significant difference in the outcomes in the patients who received omega-3. So what you're seeing in the blue boxes is the percentage of patients that had a measurable decrease on the smell testing. And you can see that at 1.5 months, the numbers are pretty similar, 24% versus 28%. But by 6 months, 24% of the patients who did not get omega-3 still had a measurable loss of smell versus the people who received omega-3, you see 4.3%. So that was a statistically significant difference in the ability for patients to recover their sense of smell. So I think that's a pretty significant finding. Some of the other important findings, though, just to consider here was first of all, there were a lot of the patients, almost a third, that actually had baseline abnormal olfaction going into the surgery, where I think a lot of patients may not have recognized that they did. We know that there are age-related losses of olfaction. So if you already have a loss but you're not aware of it, you might be much closer to that threshold where you really notice a difference before and after the surgery if you're already starting with maybe 30 or 40% loss of smell, even though you didn't recognize that. So that, I think, is an important thing, because you might say, well, everybody should take omega-3, and I think we're still evaluating whether that's true or not. But we need to recognize that even if we got you back to your very best before surgery, that may be that there's already a loss of sense of smell to begin with. So from this study, about 25% of patients experienced some olfactory loss after pituitary surgery. And this is measured with these sensitive instruments that detect numerical score changes, but they're not necessarily meaning that the patients could actually feel that they lost their sense of smell. And so there's a difference between what the actual perception is of the patient versus what's measured on the study. But nevertheless, I think it's a very interesting data. I think this it's recently completed data, so I think this may, for me, change my practices. I may have my patients routinely take omega-3 because it's just a supplement. It's very easy to do. So I think, I just wanted to share with you some of the kinds of research that we are working on at the Sinus Center to try to improve outcomes in our pituitary patients. So in conclusion, transnasal endoscopic surgery, I think, is a really excellent way to approach these pituitary tumors. And hopefully with this talk you can understand how dedicated care of the nose and sinuses is a really important aspect of that to getting our patients back to achieving good outcomes and having a satisfactory experience. Thank you very much.
I had my smell and taste for 6 days after surgery, and then it went away for a week, and then I sneezed and it came back for a few hours, and then it went away, and then I woke up and it was back for a few hours. Is that normal? Is it going to keep going in and out?
Yeah. So how long has it been now since the procedure?
It was May 2nd.
Okay. So the good news is that your olfactory nerves are probably functioning. Okay? Because if you never had it back, we don't know if it's just because of the swelling or whether the nerves were actually injured. So it's a little bit of a tease to get a little back and then to lose it. But what that probably means is that you're having some fluctuations of swelling right in those areas. I mean, those areas are exactly, those nerves, if you look at the diagram, they sit exactly above the area where we open the sphenoid sinus. So it's unavoidable to have swelling around that area. And I would counsel my patients to expect some loss of sense of smell early on. If you continue to have that kind of fluctuation, and let's say it was your second visit with me, and now you're 6 weeks out from surgery, and you still haven't gotten it back, I might add some additional medication, so we could use things like steroid nasal sprays or steroid irrigations to just kind of bathe that area to accelerate the recovery of that swollen tissue. But it's probably just a matter of time. I mean, that might move the timeline shorter, but I think ultimately in your case, because you had that sense of smell right after surgery, there's a good chance that you'll get it back to where it was.
Okay, thank you.
And what would cause loss of smell, like before surgery, where you already had loss of smell?
So there is a natural loss of smell associated with the aging process. And when we use, so the scratch and sniff test that I mentioned is a 40-item test where you actually scratch off something and then you have to identify what it is. And with 40 items, it becomes very standardized, and we can actually develop normative data for a regular population. So women retain their sense of smell better than men. That's already known, and that might be your experience at home. And then older patients tend to have lesser ability than younger patients. So if you look at the normative curves for that, they drop down like this with age, so that if you're the 90th percentile and you're 80 years old, that would actually be like the 30th percentile for a 20-year-old, because that's a natural occurring process. So it's probably just age-related degenerative processes. There are a lot of other things that can contribute as well, drug exposures, other causes of swelling in the nose, like sinus problems. These are all these other things too. So if you were to be left with a significant loss of smell after the procedure, these are some of the things that we might look at to try to optimize your sense of smell to the best that it could be. But I think the recognition that some patients may have a worse sense of smell than they actually realize is an important thing when we're talking to patients about the possible additional loss of smell.
Well, and in my husband's case, of course, it was an emergency surgery. So, and he's not aware of his loss of smell as much as I mean, he definitely has loss of smell.
Yeah.
Like a gas leak. I mean, it can be really important to.
Absolutely. And
So, anything be done about it now?
so if you're interested in looking at that, we actually do have an olfaction clinic, a smell disorders clinic that Dr. Patel runs. So some of these clinical trials she runs out of that kind of a clinic. Some of the things I mentioned, the steroid irrigations, we could try, we might try that, because we want to deliver steroids, which are anti-inflammatory, directly to the area where most of the swelling might be around those nerves. But if it's a surgical loss,
He had it before.
okay,
It's hard for me to tell if it's any worse.
yeah. So
But it comes in handy sometimes.
Right, well,
like the dog
but there
is
is a
farting,
yeah.
he can't even smell it. You know.
Right. So that's right. So I want to say one other thing that therapeutically can be done that we're also researching, and then I'll talk about the safety issues. One of the things that we are looking at is something called olfactory training. And olfactory training is actually retraining the brain. So that's occurring not at the level of the nerves in the nasal cavity, but actually retraining the higher cortical processes that process the detection of olfaction and the identification. So it sounds kind of like a weird, too good to be true, but if you take 4 essential oils of known smells and you practice smelling them, even though you can't smell them, if you do that twice a day for 6 months, you can actually show MRI changes, functional MRI changes of detection of those olfactory stimuli. And so that is something that we might offer somebody who never gets their sense of smell back after the surgery, to try to get something back. It's self-driven, so it's a patient motivated process.
Because it's very important when it comes to eating. It's hard
Absolutely.
to taste if you're not smelling, right?
Yeah.
So he tends
me,
to want
right?
spice on his scrambled eggs,
Right.
and
Right. Well, and so there is that part of it that I think is, so I think that the sense of smell is the most primitive sense of your special senses. And it's cranial nerve number 1. So out of all 12 nerves, it's number 1. So as sinus surgeons, we think it is number one. It's the most important thing. Maybe it's more important than vision, but maybe not quite. But we think that it's underrated as a quality of life issue. And so we definitely understand that. And I think that there are safety issues. So for example, you definitely need to make sure that you have smoke detectors in every room of your house, more than just the average. You need to have, the issue of spoiled food becomes an issue. It can become a social issue where people don't know how much cologne or perfume to wear, and they're wearing inappropriate amounts. I mean, there are lots of ways that olfaction can actually really interfere with quality of life. So we understand that. The frustrating thing is sometimes you have no choice in a big surgery where you say, there's no way that we can remove this tumor without going through this area, and I know that that's going to possibly compromise this patient's sense of smell. Those are difficult decisions that we have to make as surgeons. But on the plus side, I mean, at least at Stanford, we have an active interest in trying to see how people can recover some of that if that's the unfortunate outcome.
I thought I saw a question over here.
Yes.
Hi, I was wondering about long-term septum flap, when there is a flap put in place after
Yeah.
a surgery, what's the long-term outcome? Are there ever repairs that are needed, 2 or 3 years later?
Yeah, that's a good question. That's a great question. So when the flap technique was first described, it was very transformative because there were so many cases of patients who had postoperative CSF leaks where a lot of other things were tried and probably multiple procedures where it wasn't successful. So from the functional standpoint of that taking care of the problem that it was designed for, it's done a great job. The things that may not have been appreciated were what's left behind in terms of the effect on the nasal cavity. And we actually wrote a paper about that and looking at our experience with septal flaps and what happened to those patients. So the good news is that the vast majority of patients did perfectly fine. You get a relining that looks very similar, but not perfectly normal, but very similar to the surrounding mucous membranes. And patients actually would not really know that they had anything done. So that's obviously the ideal. That's probably 80 to 90% of patients. But there are some patients where removing that layer of tissue, plus having had the previous surgery, devitalizes the surrounding tissue. And because cartilage does not have its own blood supply, and when you lift away one side of the lining, that cartilage only then can get blood supply from the opposite side. But if there was bruising or some other issue to the other side of the mucous membrane that wasn't harvested for the septal flap, then that cartilage can die and you can get a hole. You can get a septal perforation. Now, septal perforations on their own are not really a problem, but if they're extended septal perforations, then they can cause whistling or crusting, noisy breathing. That's a social nuisance. If they extend up high, then you can actually have visible evidence of that because the nose will drop like boxer's nose. And actually, we presented some of our outcomes data, and then the University of Pittsburgh also presented some data. And we actually had different things that we were seeing, but they noticed more of the external issue with dropping of the nose, and we noticed more just holes without the external. But I think just, nobody likes to talk about the negative outcomes, but so it's a really good question. And so surgeons said, okay, this is like the thing that we're just going to use every time. And then we realized, oh, no, there's some downside too. So, we do want to counsel our patients that there may be things that, we accept as risks of this additional procedure, but the value of that procedure to the goal of getting your tumor out and having a watertight closure outweighs those risks. But I think it's really important to talk about those for patients because as a patient, if you're not told about it, you don't know what to expect, right? So I think it is an important conversation to have. I think we have a few more in the back and then over here. Okay.
Thank you, I appreciate that.
Yeah, I want to say how lucky everyone is that's coming to this who hasn't had surgery yet. I had 2 surgeries. They never once did anything about my sense of smell, and it's gone now.
Yeah, I think it's really, it's unfortunate. The thing is sometimes there are certain tumors where they're actually tumors of the olfactory nerve where we have to remove the tumor and the nerve, not pituitary tumors, but other things. But I think that even just preparing patients for that possibility and the expectation helps that versus something that you feel like was taken away from you without your advanced knowledge. Yeah.
We have one back here.
Yes, I had 3 separate pituitary tumor surgeries through my nose way back in 2015. And now, maybe a few years back, and also recently, I've been noticing this noise that's like a quacking duck noise coming from my nose, and I would say that people close to me, like my relatives, could hear it. Yeah. And I think you mentioned it a while ago. Is it similar to that wheezing noise that you mentioned? And my second question is there a way to make it go away? Maybe like another nose surgery or something?
Yeah, I think that's something. So the nasal endoscopy video that I showed, I included that because I just wanted to show you that the nose, even though it's kind of a mystery and a black box to most of us, there's a lot going on in there. There's a lot of structures, a lot of things that can be affected by this kind of surgery. The only way to really make a diagnosis would be to have an experienced sinus specialist have a look and help you understand why that might be. A septal perforation, where the airflow then is flowing across through both sides through the hole rather than going straight down the back, is something that I think might fit with what you're describing, but that's only something that we could diagnose by just actually looking.
Do you have a question?
Yeah, I'm kind of concerned what's left inside my nose because after I had surgery in December, and there was a follow-up surgery because there were some complications. So I know they enjoyed my nose, but I follow the procedure with the doctor, and they do the cleaning and everything.
Yeah.
But I still, when I blow my nose, I get this like coagulation thing coming out. And when I really remove with my finger, I bleed. And then if I go a little bit deeper more, there is something hard there. It looked like a cardboard or something, or a piece of metal or something. Should I be concerned with that? I'm trying to find out what's left there.
Well, I didn't bring my scope with me, so
Okay.
I would have run a clinic here for you all, but I don't have my equipment. These are things that are very difficult to answer, but what I would say is, when I showed you that schedule of postoperative care, that's assuming somebody just follows the exact path of just everything expected, right? So I have a lot of patients after the second visit, I would just tell them, I said, Dr. Fernandez-Miranda is going to send you back to me if there's anything that you need, but you don't need to make a double visit because you're already healed. But if somebody told me that they were still having issues like that, we can't just say, okay, well, you're done and call me if you need me. We continue to follow through, and I think that's part of our philosophy is that there are certain things that are the domain of the sinus specialist, right? So if you were to show up to your neurosurgeon and talk about those things, they're not going to really know how to engage you in a meaningful therapeutic way. And then it would be our expectation that you come back to the sinus surgeon to try to address those things. Now there are things, as I mentioned, that you just have to make decisions in surgery where sometimes you have to do things that may permanently alter the function of the nose. But if you're just trying to guess if that's something that's permanent or potentially reversible, that wouldn't be what we would want for our patients. We would want you to at least have that information to say, okay, at least I'm reassured that that's not something that's going bad, or that might need more surgery, or, and so we can show you, we can give you the goggles, we can scope your nose, we can help you understand what's going on in there, and that's our general approach.